Dear colleagues, this video demonstrates the technique of arthroscopically assisted three-bundle reconstruction for acromioclavicular joint dislocation. All authors of this study declare no conflicts of interest. The patient is a 42-year-old male with right acromioclavicular joint dislocation and a positive preoperative piano key sign. First observation is performed through the posterior approach, followed by dissection of the cricoid via the anterior approach. Subsequently, a lateral approach is established to dissect the subacromial space, exposing the acromioclavicular joint and the base of the cricoid. A skin incision of approximately 8 cm is made along the acromioclavicular joint and distal clavicle, revealing a complete dislocation of the acromioclavicular joint. 4 parallel tunnels are drilled using 2 mm Kirschner wires at 1 cm from the joint and 7 mm apart in distal clavicle and proximal acromial. A 4 mm suture tape is pre-placed by crossing through the acromial tunnels from inferior to superior and through the clavicular tunnels from superior to inferior for later use. Next, a self-designed reducer is inserted into the acromial to depress and reduce the acromioclavicular joint with 1 screw fixed at the proximal end for temporary stabilization. Based on the anatomical date of the cricoclavicular ligaments measured by preoperative MRI, the arthroscopic locator is positioned at the junction of the cricoid body and base. A 2 mm Kirschner wire is used for localization, and a 4.5 mm drill bit is employed to create the trapezoid ligament tunnel. The locator is then repositioned at the cricoid base to drill the conoid ligament tunnel. A PDS suture is first used to introduce the tightrope device for trapezoid ligament reconstruction. After tension, the end button device is introduced for conoid ligament reconstruction. After pulling out its loop at the clavicular end, a 2 mm plate is passed through the tail end of the loop. The reducer is removed and the tail suture of the tightrope device is in tension again. The suture tape is passed through the second distal screw hole of the tape, and the tail suture of the tightrope device is passed through the second proximal screw hole, with each noted and fixed separately. 1 screw is then inserted into each of the first proximal and distal screw holes for fixation. At this point, if the cricoid tunnel is anteriorly deviated to disperse in stress and avoid iatrogenic fracture, the tail suture at the cricoid end can be arthroscopically guided from the posterolateral cricoid to the clavicular end, pass through the middle screw hole of the plate and noted for fixation. Finally, the reduction effect of the acromioclavicular joint is verified arthroscopically. All incisions are sutured and sterile dressing are applied for dressing.